If you're in business, you probably have a website, but can your site handle your growth? How many visitors before your site slows down or crashes? What about storage and data security? From web hosting to virtual servers, Pair Networks provides the online infrastructure you need to start, grow, and flourish. When it comes to security and updates, don't worry, we've got you covered. Our 24/7 US-based customer support is the best in the industry. No frustrating chatbots or sitting on hold for hours. Check out pair.com today to learn more. That's PAIR.com.
Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, good afternoon. I'm Susan Coffin. I'm here for the first of Attitude Magazine's three-part ADHD Awareness Month webinar series. We're really pleased to welcome Dr. William Dodson with us today. He's going to be providing us with an overview of the basics. What is attention deficit disorder? What is it not? Knowing the facts about ADHD, how symptoms present in children, how symptoms present in adults, what the treatment options are, is really the key to managing this condition. And it's actually harder than you might think to educate yourself and your family members about ADHD. As many of you know, it can be a very misunderstood condition. So we're hoping that this webinar will fill in those holes, get you off to a great start understanding ADHD, give you something that you can offer your relatives and friends who want to understand more about ADHD. And we, as I said, are super pleased to welcome back Dr. William Dodson, one of our all-time great most favorite speakers. His screen is frozen right now, but that will not affect the audio. So you'll see his slides. Dr. Dodson's a board-certified adult psychiatrist who has specialized in adults with ADHD for over 25 years. He's a life fellow of the American Psychiatric Association, which was awarded to him in recognition of his clinical contributions to the field of ADHD, and the recipient of the very prestigious Maxwell Schleifer Award for Distinguished Service to Persons with Disabilities. He has a consultative practice in Colorado in Greenwood Village, and he is a member of Attitude's ADHD Medical Review Panel, where he has provided us with an incredible insights as we make sure that our content is completely accurate. A few notes to our listeners who may be new to our webinars. Dr. Dodson will give his presentation, and then he'll take your questions. Please post your questions at any time that they occur in the Ask a Question section of the screen. Dr. Dodson's slides are available right now to download in the Event Resources tab of the screen. And when the webinar ends, a post-event survey will pop up and will ask you how useful you found this webinar. That will be followed by 3 questions under a title stating required for certificate. If you would like a certificate of attendance emailed to you, please submit your answers to those 3 questions, and you will get that certificate by email. If you are listening to this on replay, please revisit the replay page on the Attitude website to get accurate instructions on how to get a certificate of attendance. So my last comment is that audio problems are usually caused by slow internet speed. So please close any open browser tabs and maximize your internet access. So with that, I'm happy to present Dr. Dodson.
Good morning. I'm Bill Dodson. What we're going to talk about today is something that everybody faces at some point when they decide to do something about their ADHD. There's quite a lot of people. The estimate is that about 3,000 families start this process every day. There are very few guidelines, though, to help people make it through the maze of all the things you have to know and do in order to get a good, thorough, competent evaluation. And so we're going to try and go through that quickly today in several different phases, looking at different aspects of it. Why don't we start with formal diagnosis, since that's where everybody has to sort of start. The insurance company wants to make sure that you meet the diagnostic criteria. Families want to make sure, do I really have ADHD? The diagnostic criteria have been around for a long time, 1980. While we've changed the name of the disorder from minimal brain dysfunction to hyperkinetic reaction of childhood to ADD to ADHD, the criteria have largely remained the same. They are behavioral criteria. In other words, the criteria were originally designed by and for researchers. They needed things that they could actually physically see and count. Consequently, they ignored a number of very important aspects of ADHD, which we will get to in just a moment. There are 18 criteria. They are divided into two sets of 9. The first one is the inattentive type of criteria. For a child to get the diagnosis of the inattentive subtype of ADHD, they have to have 6 or more of these criteria occurring often. Unfortunately, they don't define what often means. There's an inattention to details. People make careless errors in their work. They have a real hard time sustaining attention, especially in activities that are not interesting or exciting to them. They seem not to listen when talked to. They have a real difficult time sticking with a task long enough to finish it. They have difficulty organizing because it's hard to put things in order if you can't make use of the notion of importance. They avoid tasks that require sustained attention because boredom, the person with ADHD, is almost physically painful. And so they're going to avoid boring, tedious tasks. They tend to lose things. They're easily distracted. And because of all this, they tend to be very forgetful people. That's what causes them to lose things. They forgot where they put them. The other 9 criteria are called the hyperactive impulsive subtype. There are 3 impulsive, 6 hyperactive. And again, you need 6 or more of each one in order to get the diagnosis. If you're a late adolescent or adult, the number that's required for the diagnosis was decreased to 5. That really doesn't matter because what they found was 4 was equally accurate in making the diagnosis of ADHD. On the impulsivity side, you have people who blurt out the answer before the question is finished. Consequently, they often are interrupting and intruding on others, and they have a difficult time waiting their turn. On the hyperactive side, they're physically hyperactive. They fidget constantly in movement, have trouble sitting for long periods of time. They are very restless. They're up and about all the time. It's very hard for them to even do leisure activities quietly or easily. They're always on the go, and they tend to be talking all the time. God forbid that they would have a thought that didn't get utterance. If you look at those 18 criteria, the first thing that most people think is everybody does that all the time. I've said things that I immediately regretted. I've lost things. I get disorganized. I drift off in the middle of meetings. What makes this a disorder? Now, those 18 criteria, 6 on either side, are just one piece that you have to have for the diagnosis of ADHD. One of the things that was one of the big changes in 1994 is that hyperactivity that used to be the thing that defined the syndrome now is no longer required for the diagnosis. So the 18 symptoms, in order to get to be a diagnosis, have to have 4 other qualities. They have to be consistent, persistent, pervasive, but most of all, they have to be impairing. They have to be consistently there. They're always there every day. It's the backdrop against which people play out every day of their lives. They have to be persistent. They have to have been in childhood and now have persisted all the way every day to the present day. They have to be pervasive. They have to be in at least 2 major areas of life functioning. That's an easy one because ADHD manifests itself in every area of life functioning. But the last one is the real kicker. It has to be impairing. They have to be more than just lovable little traits or quirks. They have to cause significant impairment every day, all day, as far back as the person's memory goes. When you add those in, you can see that it really narrows the field pretty quickly. ADHD is extremely common. In the textbooks, you're going to see a prevalence rating of about 5%. And that's because, again, they get these numbers from research studies. In order to get somebody into a research study, they've got to have ADHD pretty badly. And so it self-selects for very severe cases of ADHD. When you look at studies that were done using DSM criteria, where they looked at whole populations, tens of thousands of people at the same time. For instance, the CDC study, the last one there, had 110,000 people in it. What you get are prevalence ratings somewhere between 9 and 11%, making it the most common neurobiological condition known to man. These are childhood prevalences, but these persist into adulthood as well. We really shouldn't expect a disorder that's genetic to go away. We shouldn't expect something that's neurological to go away. So consequently, ADHD doesn't go away. It's just most adults outgrow the childhood criteria. So let's look at ADHD, how it presents as the person develops, because it's going to, even though ADHD is the same, it's going to look differently depending on how old the person is. With preschool children, almost always the kid has to be really quite hyperactive, disruptive, obnoxious. They're always on the go. They can't sit still. They have insatiable curiosity. They are fearless. Multiple accidents. The old joke used to be that ADD stood for accidental death and dismemberment, because their rate of accidents was 400% higher than kids who didn't have ADHD. They're demanding, noisy, have temper tantrums, and really don't do what adults ask them to do. This is what, again, the slang is what they call noisy ADHD. It's something that everybody can see, everybody can agree on, and nobody can miss. When a kid has to go to school, he's the same, but the demands on him or her change. Now they have to sit in a group. They have to take turns. They have to be patient. They have to be much better behaved. And so in school, and here we're talking about grades 1 through 6, the type of child that gets identified, again, is mostly hyperactive. They're distractible. Schoolwork is poorly organized, lots of errors. They interrupt. They're blurting things out. They have real difficulty with social relationships. The old axiom is that they were the last picked, first picked on. They are perceived, the reports are going to say that the child was not school ready, which is sort of their way of saying that they're really immature. And they're unwilling or unable to do tasks at home. In adolescence, again, the ADHD is the same, school changes. The child goes off to the 7th grade, and now rather than what they're doing in class changing every 20 minutes, now it's an hour of math, an hour of history that's in a different room with a different textbook. And the kids who come to attention of clinicians at this point are usually there because they just don't have the organizational skills to be successful. The hyperactivity tends to tone down significantly, but it doesn't go away. It turns inside, and the person reports that they have an inner sense of restlessness rather than showing it on the outside. They're still disorganized. They talk excessively. But two other things emerge. One is sleep problems. The hyperactivity that went inside now manifests itself as an inability to fall asleep at night. The average length of time that they lie there wide awake is 2 hours. This is the child that can't settle down in order to go to sleep. Also, adolescents start experimentation with alcohol and drugs on average 2.5 years earlier than children who don't have an ADHD nervous system. They engage in multiple risky behaviors. They do not see danger. So they engage in speeding, they get into traffic accidents 400% more often than non-ADHD kids. Accidents continue, and they start having unprotected sex. The risk of having an unplanned out-of-wedlock pregnancy in this group goes up 1,000% because they are so impulsive and don't take precaution. You also begin to see the moods becoming much more dysregulated and out of their control. And you also see in females that the ADHD gets much worse right before their menstrual cycle begins. In adults, these are the 7 criteria that were put forward by Paul Winder. This is how adults tend to present. Their moods are all over the place. They become exquisitely sensitive to the perception that they've been rejected or criticized. Their sleep disorder gets much worse. For about a fourth of adults, it is the most impairing aspect of their ADHD. They found ways around their academic and work performance, but they're awake all night. They're very inefficient in their work. Once they do get started, they have a very difficult time getting started in the first place. Procrastination can be very severe. Winder was so impressed by the dysregulation of mood that he put it in there twice. His temper outbursts, what he called bottle rocket temper. It was done over in a hurry. The person with ADHD was past it, but everybody else was still getting up off the floor. They start looking at it as if they were depressed, but they respond very poorly to either medication or talking therapies for depression. And they don't tend to, their finances are also very impulsive and tend to have lots and lots of financial problems. So it's important to note that, again, all of these impairments continue right into adult life, but the consequences of those impairments get much worse, not just for the person with ADHD, but for everybody around them. School failure becomes job failure, underemployment, and an inability to take care of yourself and your family. Multiple injuries. A kid who rides his bike into a tree when he's 8 is going to have consequences. But a 28-year-old who drives his car into that same tree is going to have more severe consequences for more people. Drug experimentation becomes drug dependence, and on and on. So the whole notion of trying to wait out ADHD usually has disastrous consequences. The impairments and the problems, the consequences of untreated ADHD do not go away. It's important to note, though, that ADHD has positives as well. I'm not a big supporter of the current notion of the gift of ADHD, but nonetheless, people with ADHD usually are extraordinary people. The average person, the average IQ of a person with ADHD is significantly higher than it is with the general population. Average IQ, according to a study done at Duke, is 123. there's what they call cognitive dynamism. People with ADHD are constantly thinking, constantly coming up with new ideas and new ways of doing things. They have tremendous levels of creativity, artistic ability. They are great world-class problem solvers. And once they do finally engage in a challenge or task, they have what Paul Winder referred to as relentless determination. When they do make friends, they are the most loyal, devoted friends you have ever seen in your life. And they have a very wild, zany, wacky sense of humor. They're great fun to have around. Let's talk now about informal diagnosis. This is what's happening outside of the clinician's room, his office. And we're trying to figure out what's really going on that manifests itself in these 18 diagnostic criteria. As I said earlier, diagnostic criteria were designed as only things that you could actually physically see. But people with ADHD have a lot of difficulty and impairment from things that are largely outside of measurement. One of the big ones is cognition. People with ADHD think in a totally different way than the other 90% of the population who we refer to as being neurotypical. The basic notion is that the 90% who are neurotypical think in terms of importance and rewards, whereas people with ADHD really don't do that well with the notion of importance, and instead they use four other things: interest, challenge, novelty, and urgency. And we'll talk about that a bit more in a minute. Also, one of the main impairments, in fact, the major impairment for about a third of adults with ADHD, is their emotional and mood dysregulation and how tremendously reactive they are to their relationship. Sleep is also a major problem, and the effect of ADHD on all of their relationships. Their social relationships, family relationships, work relationships are all affected by the inconsistency of ADHD. So this is one of the fundamental concepts I'd like for you to get. At the heart of ADHD is a concept called interest-based performance. And that is that everything, your mood, your energy, your performance, is solely determined by your momentary sense of engagement with the task that you're doing. And that's determined by whether it's interesting, challenging, novel, and for some reason I left out the word urgent. Being merely important doesn't help most people with ADHD. Importance that organizes and motivates everybody else for a person with ADHD is really nothing more than a nag. In order for them to engage with a task, get access to their abilities, and then stick with that task all the way to the payoff, it has to be one of those four things. It has to be very interesting, fascinating to them. They have to be either challenged or competitive. The task has to be new, novel, creative, and finally, it has to be urgent. Urgency is what substitutes in a person with ADHD for importance to a person who's neurotypical. This also creates a problem in that people with ADHD sometimes, when they are able to get in the zone, function at an extremely high level. And about 45% of adolescents and adults can hyperfocus. They can get totally engaged with what they're doing and do really quite superhuman things. This problem of being engaged sometimes but not others makes it look as if it's under the conscious will and control of the person with ADHD. This is not the case. So the main frustration for people with ADHD is that they are inconsistent in a very consistent way. They are not reliable. They're never sure whether they're going to get engaged and get access to their abilities this time, the way they did the time before. This learning how to get in the zone as the situation demands is the heart of the non-medication side of therapy and ADHD management. The old axiom is that pills don't give skills. All that medication does is it gets you in the game on a level neurologic playing field. You then have to learn the rules of the game. In adults, we tend to talk about hyperarousal rather than hyperactivity. Again, hyperactivity is something you can see, you can count. Hyperarousal is something that's happening on the inside. And it manifests itself as insomnia, having multiple simultaneous thoughts, very high levels of impulsivity, and, of course, emotional overreaction and regulation. So let's talk about now diagnosis and assessment, how they're the same and how they are different. Diagnosis, means that a person meets the criteria for the condition. And that's something that's very formal. Professional organizations get together and through a lot of testing and discussion decide what the essence of any condition is, whether it's heart failure or ADHD. A person either meets the criteria or they don't. And that can be a problem because if a child has 5 very severe criteria in one group or the other, according to a researcher, they don't have the disorder. So it's a totally artificial cutoff. And that's where the patient, the parents, and the physician's judgment about impairment really decides what's next. There is no test for ADHD. And people say, well, I need to get tested for ADHD. Well, there isn't one. It doesn't show up on educational testing, which at the very best can only be suggestive of the diagnosis. The diagnosis of ADHD is made on the basis of a carefully taken, thorough history. This takes a lot of time. Therefore, it's expensive, and therefore insurance companies hate it. They don't reimburse it. Most insurance companies will cover about 15 minutes in which to do an evaluation that commonly takes multiple hours. Therefore, most clinicians would rather not do ADHD work, and they don't. Most are not even prepared to do it even if they wanted to. Half of all pediatricians report that they do not feel prepared to either detect, diagnose, or treat ADHD. The diagnosis, especially in childhood, is almost always made by someone else. People walk into the pediatrician's office telling them why they are there and that they want an evaluation for ADHD. Assessment is something quite different. Assessment looks at the person in context. What is their life like on every level, in every aspect, every activity of their daily life, and what things are going to interfere with or affect how the person is treated for their ADHD. First and foremost is the family. They're the support system, the source of resources. It has an effect upon the entire family. ADHD is a family condition, partly because it's genetic, and both siblings and parents will have ADHD as well, but also just because it has such a tremendous draw on every type of family resource. Education is probably the next most pervasive and important area of ADHD functioning. You need to look at grades, the child's attitude towards school, and the attitude of current teachers. The third big area is you need to look at coexisting mental health conditions. ADHD is probably one of the most comorbid or coexisting conditions known to man. More than 70% of people with ADHD will have at least one other major psychiatric diagnosis. 56%, more than half, will have two or more. And this is one of the things that takes up most of the time in the ADHD evaluation. You also have to look for pre-existing medical conditions that would interfere with ADHD medications. You need to assess and try and figure out the pre-existing knowledge of every person in the family about what ADHD is and isn't, and whether or not that knowledge is accurate, truthful, and helpful. There's probably no other subject I could name that has as much intentional disinformation and false news out there as does ADHD. So where you get your information is of extreme importance. You have to assess what the parental attitudes are about the diagnosis and about the possibility of using medication in the treatment of ADHD. The clinician, as part of this assessment, also has to figure out who is not supportive of assessment and possible treatment. I call these the Aunt Sallys of the world. Aunt Sally in my family was a woman who was often in error but never in doubt. She had an opinion about everything that usually was quite outlandish and based on no direct knowledge whatsoever, but that did not stop her from telling you at length what you were doing wrong. For people like this, they equate fixing the blame and fixing the problem. If they can blame somebody or shame somebody, that's as good as fixing the problem. If they can accuse you and make it stick that the real problem here is that you're a bad parent who doesn't discipline enough, they feel that their job here is done. These are people who have to be neutralized because otherwise they will do untold damage. So let's go back and look at the family. It's the single most important factor. Absolutely nothing in life prepares us to really deal with raising any child. But when that child has ADHD and or coexisting psychiatric conditions, it is often completely overwhelming. Most parents are completely out of their depth. Consequently, the need to get help is immediate and very compelling. This is a family condition, and the whole family has to understand what ADHD is, and that people who have an ADHD-style nervous system are fundamentally different from neurotypical people. Half of children and at least one parent will also have ADHD. ADHD is strongly genetic. If one parent has ADHD, the chance of any one child having ADHD as well is 50-50. Once again, you have to confront false information and unhelpful beliefs. And you have to help people accept the fact that ADHD is not going to go away if you wait long enough. You need to help people get that attitude that they need to intervene and fix the impairments as early in the process as possible. And you need to acknowledge that sometimes parents will honestly disagree on how to respond to a diagnosis of ADHD. This seems to be happen much more frequently and strongly in families of divorce. And a lot of times, family therapy is necessary before an assessment can actually be done. It's important to get everybody on the same page, and through education as quickly as possible. When other members of the family have ADHD, you need to do an assessment and consider treatment with them as well. You have to remember that treatment is expensive in terms of money, in terms of emotion, in terms of your time. It's best to explore your insurance coverage early on in the process and change to a different policy during the open season, which will be upon us next month. Also look around for coupon programs because the medications are unnecessarily quite expensive. In all of this, when you're being pulled a dozen different ways, it's not always possible, try not to neglect the siblings who don't have ADHD. ADHD are high-maintenance kids. I will grant you that, and they can sometimes suck up all of a family's resources. One of the most important people to take care of in this whole process is you. Parents can become utterly exhausted, especially if there's conflict about the ADHD in the family. So you have to take care of both parents if you're going to have anything left over to take care of the kid. School is often the source of referral, and it's usually in the elementary grades, the disruptive child who gets referred for treatment. In the later years, it's the very bright child who is not achieving or having behavior problems. Do not believe that if a teacher tells you that they cannot make the diagnosis or make referrals or suggestions about looking into ADHD. It is actually a requirement of federal law, and in particular, the Child Fine Program. You have to really very quickly assess the attitude of the teacher. The teacher is going to make or break the academic year of the newly diagnosed child. If the teacher is not supportive, if they are not competent to teach kids with ADHD, look into switching teachers as early in the process as possible. Remember that if a child is already burned out, they've had so many bad experiences and frustrations, so much shame and put downs that they are now hopeless, nothing can be done. You have to have what Sigmund Freud himself referred to as the restoration of morale. A hopeless person cannot make use of any intervention. The educational workup is not, or neuropsychological workup is not mandatory unless the patient has a significantly low achievement relative to their abilities. ADHD is not diagnosable by neuropsychological problems anyway, and the American Academy of Child and Adolescent Psychiatry strongly recommends that the ADHD medications, if you're going to medicate, be optimized before you do a learning disability evaluation in order to remove that confounding variable. The school's responsibilities are rather large, and consequently, most public schools tend to weasel every chance they get. The public school must, it's not optional, they must do a timely and complete evaluation if requested in writing by the parent. There is one of the really, really good articles available on the Attitude website about how to write such a letter. These evaluations are very expensive, and that's why the schools don't want to do them. If done privately, they typically run $2,000 to $4,000. Consequently, you may need an advocate to help you perfect your child's rights. And this is another very well-written authoritative article that's available on the Attitude website. You need to look for coexisting and comorbid conditions. And this does not yet require a psychological specialist. This can be done by most pediatricians using checklists, which means that the family is going to spend hours filling out checklists. That's your contribution to the process. Most psychiatric conditions are genetic, and so you're going to see some of these repeated in other members of the family. The most common coexisting diagnoses are conduct and oppositional defiant disorder, mood disorders, anxiety disorders, and learning disorders. That Venn diagram is a bit misleading in that it shows these being very discrete from one another, when usually it's that you have a mood disorder plus an anxiety disorder plus ADHD, and all of these circles overlap a great deal. The initial question, therefore, is not whether it's one or the other, but rather, is it both? Most symptom complexes overlap. For instance, in the DSM-4, there were 295 named conditions, but there were only 167 symptoms. So consequently, symptoms overlap a tremendous amount in psychiatric diagnoses. For instance, ADHD and bipolar, there are 14 different symptoms common. So that's where your clinician is really going to earn his or her salary, is in teasing those apart with as much certainty as possible. We need to remember that these coexisting conditions are totally separate from the ADHD. One does not cause the other. But very commonly, you're put in the position of trying to decide which one is to be treated first. Usually, that's a family decision as to which one is most impairing. Finally, there's also a medical workup, but usually, again, it's just a history. If the medical history is unremarkable, laboratory and neurological workups are not indicated. Recommendations 3 and 4 from the standard of care. The scans that are so very popular out in California are not recommended. In fact, they are to be avoided. They really have no place in the diagnosis or monitoring of treatment of ADHD. And I put in there a guidance from the American Psychiatric Association on that. Finally, there are some conditions, medical conditions, that are, quote, contraindicated. You're not supposed to treat ADHD with medication if the person has heart disease, seizures, hyperthyroid disease, or glaucoma. The emphasis should be on the word untreated. Once these 4 conditions are medically managed, once again, the stimulant class medications become the treatment of choice. The thing where most people have very little practical experience is what to do with the person who has recent or unstable substance use disorder. And that is yet another entire webinar, so I'll just sort of let that one go. The biggest problem you're going to face, and it's the initial one, is how do you find a competent clinician? There's the statistic from earlier that the majority of pediatricians and adult psychiatrists are not ready to help you. And you really, especially when the assessment is being done, need somebody who is fully involved, fully capable and trained. Once everything gets set, any willing provider can write prescriptions. So it's important to find this person up front. Don't have a bad experience as your first experience. There are a number of different ways. You can go to Attitude's professional list, and there's the web address for that. One of my favorites is to have people join CHAD, which is the organization for parents of kids with ADHD, or NADA, which is the organization for adults with ADHD. Go to a meeting. These are people who were in your shoes looking for somebody just 1 year ago. They can tell you who is good and who is not. If you can find a helpful school counselor, they know from their personal experience which clinicians get it good outcomes and which ones don't. So with that, why don't I stop and open things up for questions?
Thank you, Dr. Dodson. There's a couple of questions about diagnosis here, one from an adult and one from a parent. This comment is, my son has diagnosed ADHD, and I'm pretty sure I do too. What will a diagnosis offer me that I can't do without one? And similarly, a parent who says, let me just find this, our son is doing well in school, is doing well with friendships, has some disorganization and some other indications that they might have ADHD. Is there any reason to pursue a diagnosis? So I guess the question is, given that the diagnosis is complex and difficult, what are the advantages to these two questioners of pursuing that diagnosis versus proceeding without one?
Yeah. That goes back to one of the things I tried to emphasize several times in the beginning part of this presentation, and that is what drives diagnosis, assessment, treatment is impairment. People can have these traits of ADHD. Many times they can learn skills that help them improve somewhat. But as long as they're not having impairment, as long as they're not falling behind, as long as they're having friends and get invited to birthday parties, that sort of thing, you keep an eye on them. When they start having impairments, however, that's when things start going down the slippery slope. And you need to start thinking about other things that may need to be done to help your child or yourself deal with those impairments. What a diagnosis for a child or an adult does is it gets you access to medication treatment. And again, that's a whole extra long webinar about how to go through the angst that most families go through about deciding whether or not to make use of medication, or at least to try it and see what it has to offer. So for today, the most I can say is the medications, if, again, they are managed by a competent, knowledgeable, experienced clinician, are by far the most effective treatment for ADHD. They're just light years ahead of anything else that's been tried. And there are a number of studies that are reviewed, the 53 other non-medication-based therapies that have been tried, and they're not even in the same ballpark. So if you've tried these other interventions, they are not adequate to manage impairments, that's when you need a diagnosis in order to get a prescription so you can see what medication has to offer to you as a unique individual.
Okay. That's interesting. On the diagnosis front, continuing, could you talk briefly, I know this is a big topic, but you mentioned that it's important to distinguish ADHD from coexisting conditions such as depression or bipolar disease. And a number of people are asking, even just briefly, how to distinguish one from another, specifically depression, bipolar disorder, or a learning disability.
Yeah. By the way, there are several good webinars and articles on the Attitude website that go into this in much more detail. But just a quick overview. In order for anything to be a disorder of mood, it has to have some very specific features. The moods have to be painful. The term is dysphoric. They have to make the person feel very bad. The mood has to have come out of nowhere. The mood has a life of its own, separate from the events of the person's life and outside of their conscious will and control. If a person has a very sad thing happen and they have a sad reaction to it, that's normal. A person who has a mood disorder, things are going well, but they're in the dumps, can't move, have no energy, have no hope, suicidal thoughts, all of the different symptoms of a mood disorder. It has a gradual onset over weeks to months. It has a gradual offset over weeks to months. And by definition, a mood disorder has to last a minimum of 2 weeks uninterrupted. Let's look at ADHD. People with ADHD are extremely emotional, passionate, intense people. If they don't care about something, it's just not there on the radar screen. They care intensely about the events and people of their lives. When they do have a mood shift, it is triggered by an event. The emotions match their perception of the event. The mood changes instantaneously. In other words, it's a normal mood in every way except its intensity. The mood disorder is untriggered, gradual, and sustained. People with ADHD, their moods are constantly in change. When they get involved in their next interest, their mood is back to being good again. And the offset is fairly abrupt. So consequently, it is rare that a mood will stay stable and pervasive for that full 2-week period of time. So if you follow those general outlines, usually ADHD will separate from a mood disorder unless you've won the negative genetic lottery and you have both.
Okay. Here's an interesting question. Is there a range of ADHD? In other words, can there be a light dose of ADHD versus a more intense? Is there a spectrum of ADHD? So another person put this question this way. Is there severe versus not so severe ADHD?
The answer is, of course.
Okay.
The universe is on a bell-shaped curve. There are some people who have a light dose of fill in the blank, and people who have a heavy dose of fill in the blank. Most people are somewhere in the middle. So yes, some people have ADHD, but again, they find ways around the impairments. And consequently, they're sort of their own therapist. There are other people who quite literally cannot function because their ADHD is so severe. It's so disruptive to their ability to form relationships, to acquire knowledge, to control themselves. So yeah, there is a wide range of severity in ADHD, the way there is in everything else in the world.
Okay. That makes sense. Diagnosing girls versus boys, some questions about, is it easier to diagnose ADHD in boys? Are boys more likely to have ADHD? What do we know at this point about how gender affects diagnosis and existence of ADHD?
Yeah. Again, we'll have to talk in terms of generalities, but the old slang was that there were two types of ADHD. There was noisy ADHD and quiet ADHD. And what they really meant was the noisy ADHD was the child who presented with the hyperactive, impulsive criteria. Again, nobody could miss them. Everybody could agree on them. And they were mostly boys. When I went through my psychiatric training back before they invented DIRT, I was taught that women did not get ADHD. But we now know that women and men have ADHD in exactly the same rates. It's uncommon for a woman to be truly hyperactive, disruptive, the way little boys can. The silent type is usually the purely inattentive subtype, which is what women, little girls tend to be much more often. But a lot of little boys have the inattentive subtype as well. So just because you have a boy who's not getting thrown out of daycare, not being put out in the hall in the first grade, that sort of thing, doesn't mean that the little boy does not have ADHD as well.
Okay. So let's see. There's some curiosity about some of the positives of ADHD, which I think lots of the listeners were relieved to see that slide that said that there were a number of positives about it. Can you talk about why you think ADHD leads to intense loyalty of friends, the relentless determination, some of those characteristics? How are they related to the underlying ADHD?
I wish I could say. I really don't. I don't know. But it is striking to me how often that picture comes through with an ADHD kid who has not been alienated by the school system, by rather caustic, shaming parenting, that sort of thing. People with ADHD are remarkable people. They're bright, engaging, fun to be with, absolutely loyal people. One of the things is that they are high maintenance but high reward individuals. So there's a lot of positives that as a parent of a child with ADHD, you need to remind the child of the positives as much as you possibly can. Believe me, there are plenty of people out there reminding him or her of the difficulties they're having. You will have a friend for life if you see the positives that the child has as well.
That's great. I want to go back to the question of diagnosis, this persistent belief that ADHD needs to be diagnosed by neuropsych testing. Some listeners asking who've been told that, and some others who are asking for clarification as to why ADHD cannot be diagnosed by neuropsychological testing. And I think, if I just jump in here, neuropsych testing tends to focus on specific learning disabilities. Is that correct?
Right.
Okay, so that's
or brain damage, damaged areas of the brain. Think about what the setting is for neuropsychological testing. The student, the person with presumed ADHD is sitting on one side of a table, the examiner is sitting on the other side of the table, and the examiner is offering a new question, a new challenge about every 30 seconds. They're constantly bringing them back to engage with the topic, etc. And the rule is that the tasks get progressively harder and harder, and you move on to the next test when a person misses 2 tasks in a row. So again, one of the things that helps a person with ADHD get engaged and show how bright they are is challenge. Competition. And so if you get a kid with ADHD who's constantly being brought back to the test by the examiner, they've accepted the challenge, they want to do just absolutely the best they can, they turn out scores that look entirely, I don't want to use the word normal, but non-ADHD. Some kids, because they are more interested in some tests than others, will have what's called subtest scatter. There are 13 subtests to the Wechsler Intelligence Scale, and what you'll see is the scores will be all over the place. 6, 10, 13, 4, they'll be all over the place. That's strongly suggestive of ADHD, but not at all diagnostic.
Right.
So
I think, isn't it the case that sometimes the working memory test within a neuropsych might be indicative? What is the relationship between working memory deficits and ADHD, or executive function and ADHD? Another question.
Again, it's the inconsistency of performance based on whether or not the person can engage with the task. That's ADHD to me.
Okay.
So if you have a middle schooler who's gotten into the Harry Potter book, those kids can quote it chapter and verse. They can tell you the most obscure details of that book.
So true.
Because they got into it. They don't have any problems with working memory if, there's the big if, they can get engaged because it's interesting, challenging, novel, or urgent. Same thing happens on the neuropsychological testing. If they get into it, if they accept the challenge, they're going to look great.
Okay.
So that's why the American Academy of Child and Adolescent Psychiatry says, wait to do neuropsych testing when you're looking for learning disabilities and that sort of thing. And if you are accepting of the notion of medication, have the medication optimized so that you rule out distractibility as a cause of poor performance.
You mentioned that one does not outgrow ADHD. There's a listener who's wondering about, as we know that the prefrontal cortex of the brain matures later, especially in boys, is it possible for the ADHD to get better? Symptoms to lessen. She's feeling that they're seeing that in their son. Is it your view that the symptoms may lessen, or is this a function of learning to live with this and compensating? Or what's your view on that? ADHD over time.
Yeah, let me comment that from a totally different point of view. Whether or not prefrontal cortex maturation has an effect, yeah, it's going to have it with a non-ADHD child as well. If you've ever been around a young adolescent male and compared him to a college adolescent male, all the difference in the world, and it's mostly due to their maturing. So, yeah, maturing is going to help the person function in every area of their life, whether or not they have ADHD. What I would suggest that you look at is life itself gets progressively harder. As we move through life, things, as no good deed goes unpunished. If we succeed in one thing, the first thing that happens is you get handed the next big problem. And that's usually how people come in for treatment, is not because of a failure. It's usually because of a success that has overcome their ability to compensate for their ADHD. A child is born to the family. The person gets a promotion, and now rather than just having to manage themselves, they now have to manage themselves and 4 people who report to them. That just overcomes their ability to manage and compensate for their ADHD. So in the real world, it's usually that ADHD remains the same. It's just that life gets progressively harder and ultimately overwhelms the ability to compensate.
So perhaps that's why people pursue diagnosis later in adult life. A number of people.
The average age of diagnosis in the United States, the last time they looked, which was 2 years ago, was 31.
Wow. Okay.
ADHD is not a disorder of childhood anymore. That means that half of people who get diagnosed and treated do so after their 31st birthday.
And are there any significant impediments to diagnosis at that age as an adult?
Again, it's finding a clinician who's experienced with adults.
Right.
That's going to always be the biggest impediment.
Got it. Okay. Thank you so much. There's so much here we could go on. I want to invite all of you listeners to our second ADHD Awareness Month webinar on Thursday, October 10, which is how to have the talk, how to explain ADHD to your child, to your family, to your friends. Tough topic for everyone, especially with the Aunt Sally's of the world. And to thank you for being with us today. And you'll find much more information on Attitude Magazine's website about all the topics that Dr. Dodson discussed. Thanks, everyone. Thanks, Dr. Dodson, especially. Bye.
Thank you for inviting me.
Our pleasure.
For more Attitude Podcast and information on living well with attention deficit, visit AttitudeMag.com. That's AdditudeMag.com. That's AdditudeMag.com. That's AdditudeMag.com.